Good morning, everyone. First, I would like to thank the Summit Committee, Dr. Abdul-Wahid and Dr. Ribaz in particular, and Dr. Kaka Rasool for their invitation and also for welcoming. So for the sake of time, I'm trying to put a different view for differentiated thyroid cancer, and I can promise the oncologist, radiologist, surgeon, of course, and all the audience to enjoy the journey of this presentation. Trying just to go to the next slide, please. So each person has its own view about the thyroid cancer. For example, the surgeon has his own idea about the cancer, radiologist, oncologist, and here we try to make our idea more or less same. Okay. So if you can see, guys, here that all patients should go through these stations, and each station has a convey message for the treatment team and for the patient as well. The most important thing is stage 1, where you, here. So stage 1, we need to sit with the patient as a management team, not a single person. So the message here to the surgeon, please don't take the message, don't take the decision alone, because this may put a few extra steps to the patient and to you as well. So if we sit with the patient as a team and we talk about the risk stratification and what's the expectation in terms of treatment, then we will pass through all these stations smoothly and we'll get a perfect result. For example, to translate this, so this is the message. All things will be put in the first step, and we agreed with the patient about the management plan. For example, if the patient came in with intermediate risk, we will tell the patient we will go, for example, the first step is just to do a minimal surgery, and then we give a radiotherapy, radioactive iodine, and then the follow-up step will be like X and Y, and then agreed. During the surgery, the surgeon may realize there is a non-visible lymph node that didn't pick during the ultrasound, and they have to change from minimum surgery to total thyroidectomy. And if this not been discussed with the patient in the first plan, then there will be a hesitation during the surgery whether we go to the total or near total, or just lobectomy or hemithyroidectomy, and then many plans will be changed later on. So first, if we put everything in advance, then the result will be perfect. I'm giving an example here for intermediate risk patient. When we talk to the patient, we will need to cover all these points to have an idea whether we are going to minimum surgery or a total thyroidectomy in the first step. And if we say near total thyroidectomy, then we need to involve the nuclear medicine specialists, endocrinologists, to plan what's going to happen after surgery as well. So the plan here is just to plan everything in advance. That's why thyroid cancer always better to be treated in tertiary center rather than a general hospital, because many research and papers saying that the result will be satisfactory usually when the patient treated by a tertiary center rather than a general hospital. So in this station, we cover all this. So my colleagues already spoke about the ultrasound criteria and examination, etc. Now, whether we go with minimum invasive surgery for low-risk patient or total or near total, I'm going to leave this discussion to the surgeon later on. Now, terminology we use: lobectomy, remove one lobe; hemithyroidectomy, remove of one thyroid lobe plus isthmus; near total, complete removal of thyroid gland with minimum residual tissue; or total thyroidectomy, removal of a thyroid gland. I will have a joke with the surgeon later on about the last one. And lymph node dissection, well, most of the problem with the management come from lymph node dissection. And the reason for this, if you can see, guys, that the differentiated thyroid cancer is very common to go to the lymph node. It's 12 to 81%. And if you focus on this percentage, you may realize that there is a slight difference in this percentage. And the reason, because we rely on a different guideline and statistics, not our own statistics. But in general, we say that lymph node metastasis is very common in the thyroid. And always a heated discussion with the surgeon and endocrinologist and nuclear medicine, what is best to deal with this. Just to summarize our rule of thumb, if lymph node is very obvious during examination or ultrasound, we say it is CN1. This is obvious disease, and usually the presentation up to 35% of all patients. If lymph node is not obvious, either preoperative or intraoperative, like a doctor when he asked, this is called microscopic metastasis, and it's impossible to be picked pre or intraoperative. And most of the problem usually come from this category, and it is very high, it's 62, up to 62%. Now, if you go to the first line, this is the convey message. Not all the lymph node metastases are the same in terms of their implication for recurrence and mortality. This is very important. And this is where the patient usually panics, surgeon and all people involved in the management when they just hear there is lymph node metastasis, this is the end of the story. No, at all. So macroscopic is mean nodal metastasis, which is obvious, we say CN1, and where there is high recurrence and mortality. However, the microscopic lymph node metastases do not affect patient survival. This is very dangerous information and are associated with much lower rate of recurrence. Recurrence rate up to 2% only. And here we say, please, sometimes don't make a treatment more worse than the disease itself. So despite occult lymph node micrometastasis being found in central compartment of the neck in up to 80%, the median rate of recurrence is just only 2%, and whether or not central neck dissection is done. This is very dangerous, and we'll have a heated discussion with the surgeon later on. The findings suggest that the most micrometastases remain dormant and infrequent involved into clinical significant disease, or alternatively that radioiodine ablation is adequate. Most of patients panicking after in the follow-up when they just realize they have a lymph node metastasis. And then they think always if lymph node metastasis means we are in danger, either we die or go to a next surgery, and this is wrong information. Now, the message here, please treat as a patient based on the risk category and as a team. Don't treat the patient alone. So the fortunate that most of the thyroid cancer is differentiated, and the prognosis is excellent. And other, as Dr. Kaka said, medullary thyroid and plastic lymphoma, luckily they are less common compared to the differentiated one. So papillary thyroid always tend to go to lymph node, while follicular go to distant metastasis other than lymph node. So these are, if you finish surgery and the next step is just to put the risk stratification, because all the management after surgery based on this information. So low risk patient, all the following should be found. No local or distant metastasis, all macroscopic tumor has been resected, no tumor invasion to the regional tissue, the tumor does not have aggressive histology, no angio invasion. Intermediate, any of these. So it's either microscopic invasion of tumor, cervical lymph node, tumor with aggressive histology, or angio invasion. And high risk, as we say, is macroscopic extrathyroidal invasion, incomplete resection, and distant metastasis. If you have to ATA, I'm not going to go through this information, but the convey message here, you will find maybe, no consensus, could be. So always there is uncertainty, and this uncertainty because lack of the data and audit. So this can be just decrease the uncertainty by local experience and management team. Stage 3, radioactive iodine. Usually we give to the intermediate and high risk, as Dr. Kakal said. However, a neuroscientist is saying low risk can still receive radioactive iodine when there is a warning feature or a certain feature that radioiodine can have a role in the low risk. So when it started, as Dr. Kakal said, in 1920s, yes, but started in clinical life in 1940s. But Iraq was lagging with the radioactive iodine because he was under the, there's a band Saba called, there's some US restriction to Iraq, which is then just relieved. So what is the best time to give radioactive iodine? The best time is with the first 3 months after surgery is the best time for it. Don't delay after this, please. So we have 3 contexts in terms of radioactive iodine, why we give it. First, for imminent ablation. Now I will put a question for surgeon and then we will discuss. Do you believe in terms of total thyroidectomy or not? So always when we go to the post-radioactive iodine, 99% you will find a remnant tissue, which is around the recurrent laryngeal nerve. And that's why they say we need to rediscuss about the term of total thyroidectomy. Now, remnant ablation is very important. This will make the specificity of thyroglobulin high and also for post-thyroid scan as well. Adjuvant treatment when we talk about the micrometastases, and also as a main treatment when there is persistence disease, either shown by thyroglobulin raising or just by anatomical imaging. Now, what's the benefit? The benefit, as we say, just to destroy the microscopic metastases, which is up to 80% in differentiated thyroid cancer, decrease risk of recurrence, improve disease-specific survival, and improve progression-free survival.
2 minutes.
So we're giving to high risk and an intermediate and in selected low risk patient. The dose, I'm not going to go through this. Dr. Kakal already spoke about this. So remnant ablation up to 50. Any dose above 50 is not going to get any benefit in terms of ablation. Micrometastasis is up to 150 and 200 for distance metastases. Don't give iodine doses as a small divided dose because this goes stunning. The patient should always have total or near total. The problem with radioactive iodine when we have a big residual disease, it's mean up 2 cm and above, and this is very important. We will always ask the surgeon to remove this. And the main clinical problem, usually the patient come with partial recurrent laryngeal nerve. You give iodine, this 2 cm will swelling and end with stridor. And this happens frequently. So patient preparation, I'm not going to go through this for sake of time, post-treatment scanning. So this is how it is look like. The picture in the middle, where there is a remnant, always 99% after surgery, we'll see this. And the question why there is always remnant, the remnant, I think, technically the surgeon will talk about to preserve the recurrent laryngeal nerve. And this is how it is look like. This person before radioactive iodine, residual disease with local lymph node metastases, and this is after treatment, completely cured. It's a focus image. This is a progression. Not going to talk about this. When we discharge patient home, when the radioactive iodine go to a safe level, usually within 1 to 2 days max. This is the most important thing. After we discharge patient, we just follow the patient just with TSS suppression. And the message here, please don't do TG or anti-TG in the first 6 months after surgery. There is no rule for this. radiation protection precaution for a patient. Usually after 1 month, the patient will be free of radiation. Dynamic risk stratification, the follow-up, it will base mainly on thyroglobulin and also ultrasound criteria, plus minus diagnostic radioactive iodine. It's not necessary always. And this is the excellent response when the TG, stimulated TG below 1 and there is no ultrasound evidence of recurrence. Intermediate response when it is below 10 and there is non-specific ultrasound finding. Incomplete response when the TG above 10 and there is structural disease. Now, how to improve our local practice? You may guys already have this service. I'm talking about our practice. Using thyroxine instead of withdrawal method. Usually, after surgery, we ask the patient to stop thyroxine for 1 month. Most of patients, especially the elderly, they complaining from debilitating feature of hypothyroidism and is unpleasant experience. Giving thyroxine will just make them feeling better and make the radioactive iodine treatment quick. But the problem with the thyroxine is very expensive. So they usually 2 vials and the price is $4,000. And last one, is occupational and learning disability team should be involved in radioactive iodine. And we should add the molecular marker for FNA to increase the specificity. Thank you very much.